Let's start now.
Great. Good morning and welcome. I'm Allison Moore, Chief of Geriatrics, Gerontology, and Palliative Care, and Vice Chair of Justice, Equity, Diversity, and Inclusion in the department. It is my very great privilege to introduce Dr. Sharon K. Inouye this morning. Dr. Inouye is the Director of the Aging Brain Center at the Hinda and Arthur Marcus Institute for Aging Research at Hebrew SeniorLife in Boston, Massachusetts. She holds the Milton and Shirley F. Levy Family Chair and is a professor of medicine at Harvard Medical School at Beth Israel Deaconess Medical Center. She's an expert in geriatrics and gerontology, public health, health policy, and epidemiology, whose research has been unbelievably impactful for older adults, their families, scientists, health systems, and others. She is an outstanding leader, mentor, and geriatrician. Her research focuses on delirium and functional decline in hospitalized older persons. She developed a scientifically proven method for reducing delirium in hospitalized older persons, the Hospital Elder Life Program, or HELP, which has been implemented in hundreds of hospitals worldwide. Before this, she created the Confusion Assessment Method, or CAM, which has been translated into more than 20 languages and has been used in over 10,000 publications, and I'm sure more the hospitals than that to date. The original paper for the CAM was published in 1990 in the Annals of Internal Medicine from work I believe she did as a fellow in the Robert Wood Johnson Clinical Scholars Program at Yale. Dr. Inouye has received funding from the National Institutes of Health since 1989, with more than 80 grants, including an active more than $13 million PO1 grant on the interrelationship of delirium and dementia, the Successful Aging After Elective Surgery, or SAGES study. She is multiple principal investigator of the Nidus II Delirium Research Network. She's published more than 350 articles and was named by Thomson Reuters Science Watch as one of the world's most influential scientific minds of the decade. Dr. Inouye has also been awarded many of the highest accolades in medicine and science. She serves as associate editor at JAMA Network Open. She is an elected member of the National Academy of Medicine, Association of American Physicians, and American Society of Clinical Investigation. She currently serves on the Board of Health Services, the National Academies of Science, Engineering, and Medicine, the President's Advisory Council, the National Academy of Medicine Grand Challenge in Healthy Longevity, the Advisory Board for the American Public Health Association National Academy of Medicine COVID-19 Conversation Series, and is a National Academy of Science, Engineering, and Medicine committee member for improving the representation of women and underrepresented minorities in clinical trials and research. She has served as a Health and Aging Policy Fellow and American Political Science Association Congressional Fellow, and was recognized as a PBS Next Avenue 2020 Influencer of Aging. I am grateful to know her and to have been influenced by her personally and professionally. Thank you, Dr. Inouye, for speaking with us today. Thank you.
Thank you so much for that introduction. And I'm so delighted and honored to be here today. I just want to make sure you can hear me. Everyone can hear me okay?
Perfectly.
Okay, thank you so much. You know, when I was invited to give this grand rounds for you, I was just delighted to do it. I do feel so closely connected to UCSD because of a very long-standing relationship I have with Allison. We think dating back possibly 3 decades, and she was also the primary care geriatrician for my mother when she was at UCLA. And you know, you think very highly of someone that you choose to take care of your mother. And so I just feel in a way like I'm coming home, and I'm so delighted and honored to provide this talk for you today. on an update on delirium in older adults. And we'll talk a little bit about delirium and COVID as well. So just a reminder about that QR code here, and the instructions to claim your CME credits are in the chat. I have no conflicts to disclose. So I was asked to start with a little bit of a personal story about my journey. And I thought perhaps the most relevant thing for you would be, how did I wind up in the area of delirium research? So it's a longer story, but I'll tell you the abridged version. Really, for me, it all started at the bedside. So I didn't immediately go into geriatrics out of training. I actually couldn't decide on my subspecialty. I loved every field in my residency, and so I couldn't narrow it down on time to fill out the fellowship application. So I ended up doing, general medicine. And then in my first real job after training, I actually landed a job in general internal medicine at the West Haven VA Medical Center. And I attended there on the general medicine service, as well as on the intensive rehabilitation unit, the nursing home care unit, and the geriatric unit. And on my very, very first attending block, now as a general medicine attending, so this is post-training, I saw, this is in 1985 now, so really dating me, 6 cases of an acute confusional state, unnamed it yet at that time, during this very first rotation. All of them had poor outcomes. So of these 6, 2 went to the ICU, 2 who had been independent on discharge needed to go to a nursing home, and 2 died. And so if you remember your first stint as an attending, I took all those cases so seriously. And after it was done, I just, kept thinking about them and what went wrong. I talked to the senior physicians and colleagues at the West Haven VA as this was happening, and said, I have these older adults becoming very confused on my service, and it just seems like something, I don't know what's going on, how do we manage this? What is that all about? What's happening? And I was told to a person, Sharon, don't worry about it. That's just something that happens in older adults. We see it all the time. So I was told different versions of that very consistently by my colleagues. And I couldn't stop thinking about it. I couldn't stop worrying about it. And so after my stint was over, I went down to medical records and pored over all of the charts, like foot-high stacks of them, to figure out what went wrong. And I made these huge graph papers. This was in the days before Excel, charting out every day, every medication, everything we did to those patients, and charting out in my notes, because I was documenting how confused they were that day. And I concluded that we, the medical care team and myself, had contributed to the problem through medications and procedures and immobilization and UTIs with indwelling Foley catheters. And I realized to make a difference, I needed to get some research training and understand how to study this area. And so, and that evolution took a long time, but that's basically the story. And that's how I began in the area of now called delirium. So what is delirium? So I did end up getting that research training, creating the CAM during my research training, as you heard from Allison, because you have to be able to measure what you want to study. And there was no published measure back then in 1985 and 86 when I wanted to start in this area. But this is now how we currently define delirium by DSM-5 criteria. And these criteria are a disturbance in attention or awareness. The disturbance tends to develop acutely and tends to fluctuate over the course of the day. An additional disturbance in cognition, so it is a cognitive disorder, and that disturbance can be almost anything: memory deficit, disorientation, language impairment, visual perceptual impairments. All of these are common during delirium. In order to diagnose a delirium, it cannot be better explained by a pre-existing dementia, and you cannot assess it in the face of severely reduced level of arousal or coma. And really, there should be evidence of an underlying organic etiology or multiple etiologies or a suspicion of a medical cause. So it is firmly a medical condition. It crosses between, medical and psychiatric conditions. And that's also what interested me, because I like these problems that are very complex and very multifactorial. That's what geriatrics is all about. So why is delirium important? Well, it's a very common problem. It has serious complications. It's often unrecognized. It has a complex multifactorial etiology, typically in older adults, and it's potentially preventable. And it may be a potentially preventable contributor to permanent cognitive impairment, or it may accelerate long-term cognitive decline and dementia. And I will touch on that later in the talk. I'm going to run through each of these bullet points for you with evidence. So in US hospitals today, about 5 older patients become delirious every minute. I just want to let that sink in for a moment. 5 older adults every minute. During the course of this grand rounds, 300 people will become delirious in our country. It's 2.6 million older adults each year, and that's probably even an underestimate, because that's only based on what we measure. So delirium is common, and here are the rates from published studies and meta-analyses. And I think you can see that delirium tends to be frequent in various healthcare settings. In medical units or in general hospital settings, the prevalence on admission ranges from 14 to 24%, and then the new onset during hospitalization from 6 to 56%. So you actually have to add up these numbers from 20 to 80% to get the true occurrence rates of delirium. So you can see it's very high. Other high-risk settings are the postoperative setting, the ICU setting, nursing home and post-acute settings, and palliative care, end-of-life settings where delirium occurs in up to 80%. And many palliative care physicians say that, patients typically pass through delirium at the end of life. The other thing I want to stress is the case fatality rates are very high, ranging from 22 to 76% in the hospital, and 1-year mortality rates of 35 to 40%. And these rates are so high, often because of the conditions that can lead to the delirium. Obviously, delirium occurs in patients who are sick, but the delirium itself can lead to agitation, over-medication, other things we do to patients that can also, unfortunately, increase mortality. And I want to stress this point because these hospital mortality rates are so high, and yet delirium is routinely missed, right? If you think of other conditions in older adults that have equivalent mortality, like acute MI or sepsis, those are not conditions that are readily missed, but delirium in 2/3 of cases is missed, even by the healthcare team taking care of them. And it's common, and we'll talk more about why maybe delirium is so hard to recognize. Delirium is associated with serious complications. You've already heard about the mortality, also increased morbidity, cognitive and functional declines, increased rates of subsequent dementia. We'll talk more about that. Increased need for nursing home placement, increased length of stay and healthcare costs. And then the personal costs of delirium are being increasingly recognized. The post-traumatic stress disorder that patients can have, and also the fear and tremendous degree of caregiver burden that can occur during and after a delirium episode. So not too long ago, just before COVID, we did a qualitative study with in-depth, hour-long interviews with patients who had survived delirium, with their family members, and with their nurses. And the quotations of the patients who remembered their delirium episode, many do not remember their episode or report it kind of like a hazy memory, like a bad dream. But of the patients who remember it, they describe fear, outrage, feeling unsafe, feeling out of control, feeling unprepared. I was afraid, not knowing where I was. I was not able to say what I wanted to say. It was very scary. I couldn't communicate. I was outraged that I should be treated this way, with chiming beds and people coming out of walls. As I read these quotes and these excerpts, tears were just running down my face. And I've spent my life working in delirium, and just the impact of what these patients experienced, I can tell you it has made me 100 times more patient at the bedside. And I hope that the next time you see someone suffering from delirium, you will think about how fearful they are feeling inside. And that will help you be more patient and hold off on those restraints or those bed alarms and the bed rails up, and maybe help with patients' reassurance and the things we need to do that are non-pharmacologic and take time, but can make all the difference in the world. And getting the family, right, the extra effort that's needed to get the family to the bedside. So delirium is expensive. You've already heard that. Over $8 billion per year in recent estimates for the attributable costs due to delirium. And the post-hospital costs are even more expensive and staggering. And these are costs for rehospitalization, for formal institutionalization, for formal rehab services, for home care, formal home care services, and then costs we don't measure, the caregiver burden, the out-of-pocket costs for the family, the days lost from work of the family or the patient, are tremendous societal level costs. So these costs I report to you are only the healthcare costs. Okay, so how do we identify delirium? The first and most important step. And I have to tell you again that it can be difficult to recognize delirium, and the best clinicians can miss it. It fluctuates. The symptoms can overlap with dementia, as you've already heard. They can be mistaken for a depression. Even the best clinicians can be fooled. And so we have to have ways that we train ourselves to always do in order to have our antenna up to suspect delirium. And so one thing is you need to have, a quick tool that you use. There are at last count over 45 published and validated tools for recognizing delirium. The confusion assessment method, or the CAM, is the most widely used method worldwide. It's been used in over 5,000 original published studies to date, translated in over 20 languages. It's available instantly and free of charge on the American Delirium Society website, as well as on the American Geriatric Society website. The short version is a 4-item diagnostic algorithm based on the features of acute onset and fluctuating course and inattention, and then either disorganized thinking or altered level of consciousness. And I'm going to show you on the next slide a very quick way to assess that. The long CAM, or the 10-item version, is typically used where you need a more definitive diagnosis, such as for a research study or a reference standard clinical rating, for instance, it is used for that. The link to the AGS co-care site is at the bottom of this slide. So here is a hot off the presses way to assess delirium. It takes less than a minute. It's called the UB CAM, or the ultra brief CAM. And this was developed by Dr. Ed Marcantonio and Dr. Donna Fick. And it's highly sensitive, highly specific, and it includes actual questions and assessments to rate each of those features of the CAM. And why it takes less than a minute is it uses an algorithm that if any of the items are positive, then you skip to the next item. And there's actually an app that enables you to do this quick and easy. It's available in the App Store. If you search under Delirium in the App Store, you will get to the UBCAM. And so that's available free of charge. We would love your feedback on the app if you try it out, because we're still sort of in this beta testing and development phase. So now to the causes of delirium. So delirium is typically of multifactorial etiology. And I want to stress this. Of course, it can be caused by just one thing. And we see that, pretty often in our older population where someone's admitted to the hospital and then they get a sleeping pill, and during the night or the next morning, they're very confused. And so that is likely a delirium, caused by that sleeping pill. But I would wager that it was a very vulnerable patient to begin with. Let's say they probably had other factors, other illnesses that they were admitted for. They have multiple chronic conditions. They were on multiple other medications. Maybe they had a bit of vision or hearing impairment. Maybe they had a bit of baseline cognitive impairment. That's a very vulnerable patient, right? So it only took one dose of a sleeping medication to tip them over. So that's what I'm trying to show you about this multifactorial etiology. Just a single dose of a sleeping pill, but a very vulnerable patient. But conversely, you can take someone who's not vulnerable. I would wager I could take any of the 140 of you on this grand rounds, myself included, and make us delirious if I exposed you to multiple psychoactive medications, general anesthesia. I didn't let you sleep for a few days. I put you in an ICU. I immobilized you. I put a Foley catheter in, gave you a UTI, and you underwent major surgery on top of that. Do you think you might be delirious after that? I know I would. But that's sort of the example, like anyone can become delirious, right? It's just a matter of the baseline vulnerability and then what you're exposed to cause that. And so it's important for us to remember that as clinicians, because you're not going to solve the delirium just by solving one thing, right? Even that patient with the sleeping pill, you might not get them out of the delirium by just removing the sleeping pill. You may have to go back and address, because once you set off that cascade of delirium and all the things that are going on pathophysiologically in the brain, it's much harder to get people out of a delirium than into it. And so prevention is so important. We're going to talk more about that. But to get them out of it, it's very likely you're going to have to address the vulnerability factors as well. So you're going to need to correct that very mild hyponatremia. You're going to need to get them mobile and back on a schedule and get them eating and, et cetera, et cetera. You're going to need to address other factors, get their vision and hearing taken care of as well. So predisposing factors, so thinking about that axis of vulnerability. So this is from a systematic review of their literature looking at validated predictive models for delirium. And these are some of the common factors that increase vulnerability. We've already talked about a number of them. Dementia and cognitive impairment are the biggest risk factors for delirium. And history of delirium, functional impairment, vision and hearing impairment, comorbidity and severe illness, depression, history of TIA and stroke, alcohol abuse, and older age. And so I flash these up here mainly to have you thinking, okay, if I have someone who I admit to my service, and let's say they have underlying dementia, cognitive impairment, they're hearing impaired, they have multimorbidity, right? And a lot of our patients fall into those categories. I am going to be extra careful in what meds I prescribe, making sure we don't immobilize them, making sure they have their glasses and hearing aids so they can see and hear. You know, I'm going to try to have their family there to reorient them during the day. I'm going to think preventatively about the care of these high-risk patients. And then thinking about the other side of that axis, right? So thinking about the precipitating factors now, or the insults over here. Again, from the same systematic review, validated predictive models, we looked at the precipitating factors, or the factors that occurred after admission to the hospital, and what were some of the things identified in prior studies. So medications were the most common precipitating factors, and we'll talk more about those in a moment. So multiple medications added in a single day, psychoactive medications, so medications that have known psychoactive side effects, sedative hypnotics like sleeping meds, physical restraints, bladder catheters, laboratory derangements such as dehydration or renal impairment, abnormal sodium, glucose, potassium, calcium also, hypocalcemia, and hypercalcemia, is the bigger actor for mental status, metabolic acidosis, infection, any iatrogenic event, and major surgery as well. ICU is another high-risk setting, as we know. So a moment about medications, the most common precipitating factor for a delirium. So there are many medications, right, that if you read the package insert, they have confusion or altered mental status listed, in their adverse effects. It's very, very common. But I want to call to your attention, the American Geriatric Society has developed and regularly updates what they call the Beers criteria for potentially inappropriate medications for the elderly. Okay, and the latest iteration was in 2019. And these are derived, they're evidence-based, based on systematic reviews with expert input. And the list of the key medications associated with delirium are anticholinergics as a group, and in particular, things like antihistamines. And we know many of these are available over the counter now. And the worst actor is diphenhydramine or Benadryl, which is commonly used for allergic reactions, even for sleep. And so we need to advise our patients and be very careful ourselves in the use of these medications, tremendously anticholinergic. Antipsychotics, benzodiazepines, corticosteroids, steroid psychosis is delirium. H2 receptor agonists like ranitidine, also now available over the counter. Meperidine or Demerol of the opioids is the most commonly associated with delirium, and benzodiazepine receptor agonists like Zolpidem. Now, I don't want you to come away from seeing this slide and saying, oh my God, I'm never going to use an opioid or a steroid or an anticholinergic med in older adults, right? We can't do that. There are many cases where we must give these medications. If it's alcohol withdrawal, we must give a benzodiazepine. So they can't be avoided, but the message that I do want to give is think about, is there something in that class that is less toxic, that maybe has a shorter duration of action, a more specific, if it's a beta blocker, can I give one that doesn't penetrate the blood-brain barrier as much, so just think about which could be less toxic. So for the opioids, right, like avoid Demerol, like maybe I can give morphine instead, and so forth. Okay, I want to move now to prevention of delirium and tell you about the hospital Elder Life program, which you heard about, which was originally published in this clinical trial in the New England Journal in 1999. This was the first time it was ever demonstrated that delirium was a preventable medical condition. And someday I'll tell you the story about the hate mail that I received because of that. People who had devoted their life to delirium and did not feel it was preventable and felt that I was belittling delirium by stating it could be prevented by things like non-pharmacologic approaches. We now, over the course of time, have been able to demonstrate that it's true. Delirium can be prevented and prevented quite effectively. Some studies even showing as high as 50 to 60% of cases of delirium are preventable through this approach. Our studies showed about 40%, 30 to 40%. And so what are some of those interventions? So they include, for cognitive impairment, we targeted these 6 risk factors for delirium. They were known, published risk factors for delirium at that time. And so we wanted to target each of those with practical things we could do at the bedside that we also thought would be potent for preventing delirium. So they included, for cognitive impairment, consistent 3 times a day reality orientation, therapeutic activities. So that was fun and engaging and cognitively stimulating activities at the bedside, a non-pharmacologic sleep protocol, which was a hand massage or back massage, glass of warm milk or herbal tea, and relaxation music. Very effective for inducing sleep without a sleep medication. We had a unit-wide sleep enhancement protocol, try to make the unit very quiet, no use of overhead paging, no use of those really loud vibrating pill crushers right outside of patients' rooms, and so forth. We tried to get them not to strip and wax the floors during the night. And so we made a lot of changes, but it required interviewing the patients every morning about what kept them up the night before and then trying to change that. We had an early mobilization protocol. Everyone got up and walked 3 times a day. That made a huge difference. We minimized immobilizing equipment, no restraints. Foley's came out right away. Oxygen, everybody had portable oxygen tanks by their bedside and so forth. Vision and hearing adaptation, so people could see and hear at the bedside. We provided these as well. And then early recognition, volume repletion for dehydration. So this is our team making rounds, our help team. This is one of our volunteers walking a patient. You can see she's wearing a hearing amplifier device, very inexpensive device. And this is a volunteer doing one of those cognitive stimulating activities. This is a reminiscence activity. But I think if you look at the faces, you can see why our patients love the program. After a while would refuse to go up to a hospital room that didn't have the help program on it, and why our volunteers have very long longevity with our program. It's a way to reintroduce, right, humanism in the way we take care of older adults on our units. And it works. So in over 25 now published clinical trials, this article summarized, I think, 11 of them at that time, back in 2015. It's been demonstrated that HELP and programs like HELP very successfully reduced delirium here to an odds ratio of 0.47 or 53% reduction of delirium in over 3,700 patients. The other amazing thing is if you prevent delirium, you prevent falls. I think geriatricians, right, will not be surprised. Falls are the leading reason for falling in the hospital. Delirium is the leading reason for falls. And if you have a program like HELP that is keeping people active, mobile, strong while they're in the hospital, they're much less likely to fall. And so this is actually, HELP is the most effective for preventing falls in the hospital. And here in 4 of the clinical trials that looked at falls in this systematic review, the odds ratio for falls 0.38. So huge reduction, right? Nearly 70% reduction in falls. So HELP prevents cognitive and functional decline, decreased hospital length of stay, decreased nursing home placement, fewer readmissions at 90 days, decreased sitter use, and cost savings, tremendous cost savings, both for the hospital stay, it's about $1,000 per hospitalization if you prevent delirium, and about $10,000 in long-term care costs. So I'm going to fly through these slides because of my time, but I did want to mention a couple of the studies from our SAGES program project that you heard about, because we are actively engaged in still trying to figure out what causes delirium. I want to acknowledge my incredible SAGES PIs here, shown by one of our postdocs who made this slide for us, showing us as superheroes. And indeed, they are superheroes, the PIs on this study. So it's a program project grant. We have had over 130 publications now out of the SAGES study. It's 560 patients age 70 and older undergoing major scheduled surgery who have no dementia at baseline. They complete an interview in their homes with a comprehensive neuropsych battery, frailty measures, functional measures, depression measures, and then they're followed every day of their hospitalization for delirium assessments. And then they undergo follow-up assessments again in their home at 1 to 6 months. And every 6 months thereafter, we're now out to over 7 years of follow-up. They all receive phlebotomy at baseline, and at 4 time points, a third of them got MRIs at baseline and 1 year follow-up. And so a couple of just appetizer portions of a couple of the studies. This was a study we did at the end of our first cycle, where we demonstrated that delirium is the most frequent postoperative complication in older adults. And it had greater effect at the population level than all the other major postoperative complications combined. And it had strong associations, obviously, as we already know, with length of stay, institutional discharge, 30-day readmission, and any adverse outcome. And the reason why I want to highlight this study, the reason it's so important, is delirium wasn't routinely included on any of these postoperative complication guidelines. You know, it wasn't in the accordion system. It wasn't in many of the other surgical systems. That has changed now since this publication. And so we were very proud that this work was able to get out there and make a difference. And now postoperative delirium definitely tracked by many, many hospitals as a major complication of surgery. And things are being done to address it. Another area that we're actively working on, and so important, is the long-term consequences of delirium. Because I think it, you know, I was taught, well, delirium wasn't taught when I was in medical school. I didn't even know about it, as you saw when I was an attending. It wasn't taught. But when it started to be taught in medical school, it was always taught as a completely reversible condition, right? And even if you look back at textbooks, going back about 10 or 15 years, it's taught that delirium is reversible. And if we turn that on its head and show, well, okay, for a lot of patients it's reversible, but actually for many patients it's not. And it may lead to accelerated cognitive decline, then that would change, right, the importance of delirium. So in the SAGES study, delirium occurred in 24% of the patients, of the 560 patients. In both groups, delirium and non-delirium, they had acute cognitive decline by complete neuropsychological testing at 1 month. But in the non-delirium group, they were totally back to baseline by 2 months. And then they gradually declined, as you see, with normal aging out to 36 months. I'm going to show you the curves in just a moment. But in the delirium group, it's a different story. So to orient you here, on that y-axis is our general cognitive performance measures, composite measure of our neuropsych test battery. And then it's a timeline here on the x-axis going from 0 to 36 months or 3 years. It's on a logarithmic scale. And why did I do that? Because if I show you it not on a logarithmic scale, you can't even see what's happening at 1 and 2 months. So I just wanted to spread it out so I could show you the delirium group is the group with the dotted line, and its confidence interval is in the blue shaded area. And then the no delirium group is the solid line, okay, with the red or pink shaded confidence interval. The straight line going across is the baseline for both groups. And so what I want to show you is both groups, as I already said, decline at 1 month. At 2 months, that both groups have actually improved above their baseline, okay, at 2 months. And we think that improvement above baseline is a little unmeasured or uncorrectable retest or learning effect. Then the delirium group, the non-delirium group declines at the pace of normal cognitive aging, and actually they're not statistically significantly different from baseline at 36 months, but the delirium group declines dramatically, more significantly, and they are significantly below baseline at 36 months. And in fact, they're declining at a rate that's equivalent to what's described in MCI. Okay, so an accelerated pace of cognitive decline. So this is an epidemiologic study. We can't say anything causal at all, but it raises concerns and it needs to be further evaluated. And ideally, what would be done is a randomized controlled trial of delirium prevention, and then see if we could change those curves. But there are many other converging lines of evidence to think about whether delirium leads to dementia or not. In dementia, we know delirium accelerates cognitive decline and worsens outcomes. There are many published studies that have shown that, including from our group and others. There's clinical pathologic evidence from multiple studies out of the Vanta 85+ cohort by Daniel Davis that shows a differing pathology following delirium that seems to be different from Alzheimer's disease, and definitely an increased rate of this pathology. And there are shared biomarkers between AD and delirium, and also there are mechanistic and animal studies that suggest that delirium may have some permanent consequences. So I want to now, just in this final minutes, talk about delirium and COVID-19. And because I know you are probably acutely aware of a lot of this already, I'm going to go through it quickly. So as we all well know, severe COVID-19 infections occur very often in older adults, and in the early waves, it was preferentially in older adults. Now that this population is so well vaccinated, much less, but still they're vulnerable. And studies have suggested high rates of delirium complicating COVID-19 infections that are symptomatic, particularly if people wind up getting hospitalized. And rates were documented early on in studies of 25 to 33% in medical patients, 55 to 65% in ICU patients, and a high associated mortality with COVID patients, older patients who became delirious. It's often, and this is very, very important for us to all be aware of, it's often the presenting symptom of an acute COVID infection. And just as we know that, delirium can be the barometer of illness in older adults, in fact, it was the 6th most common presentation of COVID-19, delirium, to emergency departments across the country in a study that we conducted and was published in JAMA Network Open. It has an atypical presentation, not presenting with fever, shortness of breath, cough, the classic presentation on the CDC guidelines, in from 12 to 41% of older adults across multiple studies. And delirium, again, can be the primary symptom in 16% and the only symptom in 37%. And so it's something we don't want to miss. I wrote in, I called, I emailed all my friends and colleagues at the CDC to try to get delirium in older adults added to the CDC symptom checklist. We got it added at WHO, but it is still not added to the CDC. They did add like a separate section on older adults, but not to the primary checklist. So just be sure your ED people know how often it can present atypically in older adults. So the etiology of delirium and COVID-19, I think we all know about the inflammatory pathways, the cytokine storm, the hypercoagulability, multiple organ system impairment. But what I want to remind everyone is that reversible factors, medications, prolonged mechanical ventilation, immobility, tremendous social isolation, loneliness, circadian disruption, fear, emotional stress. These are all still there big time and can precipitate a delirium. So please don't forget that. So even as our hospitals are shut to visitors and have essentially become delirium factories, right, for many older adults who can't understand the nurses or the physicians talking through masks, and everybody's rushed and everybody's afraid and there's shortages of everything and there's no visitors around. We had created another epidemic within the pandemic, and there are things we can do. And if you go to this link at the bottom, there's a toolkit that we've prepared for you to help do these activities. It's help at the bedside with a gift box you can deliver to patients that provides ways to keep them oriented, to do therapeutic activities, to do sleep enhancement, despite, not having people in the room at night, early mobilization, hearing and vision adaptations, reminding them about nutrition and fluids, and getting the families in there when you can, and avoiding psychoactive meds and performing med reviews. So the pearls about COVID and delirium, delirium, I think, has assumed heightened importance, during the pandemic. You would never see it on the front page of the op-ed page in the New York Times, other than during COVID. Okay, everyone came to realize how important delirium is. And so this is an opportunity for all of us in geriatrics. It's on the front pages, right? Our organizations need to be aware of this, how important geriatrics is during this pandemic, more than ever. All older patients should be screened since it can be missed, and atypical presentations are common, as you've seen. Delirium is multifactorial. We need to remind everyone. We need to look for those reversible factors. We need to build in non-pharmacologic approaches as our mainstay to care of older adults. And we need to find creative ways to create that new normal, right? We can do it. We need to figure it out. If this is going to remain the way it has to be, we have to figure out how to do better and bring family caregivers back to the bedside. The long-term outcomes, right, from COVID remain unclear. Many believe there is going to be long-term disability, an increased risk of dementia, definitely the need for long-term rehab and support. And so we have to plan for that and build that into our systems. And so now to take us back to delirium in general. So why is delirium important? I think, as you've seen, and I hope I've convinced you, it has tremendous healthcare costs and policy implications. You know, that's why it's a public health issue, and we need to address it, and we need to do a better job at our healthcare system level and at the population level. It's an indicator of the quality of care that our elders receive in our healthcare system. And it helps us understand the brain, right, in fundamental ways. And I also believe, and for those of you, you know, very interested in the care of elders, that it will help us prevent cognitive impairment and dementia if we can work to prevent delirium. So in closing, you know, we just want to think about our goals. And as a geriatrician, I know my goal is to keep my patients with that quality of life, creating new memories, right? Not losing their memories, and in roles that they enjoy to the end of their days. So if you are interested in learning more about delirium, I wanted to give you some resources. This is the link to our AGS Co-Care Help program. You can learn about starting a help program. We have a delirium research network. Even if you're not sure, you're just curious, please look at the resources we have. We sponsor webinars pretty much every month. Sometimes every 2 months, we have an intensive boot camp. Here's my email, it's our Twitter, and again, the QR code for your CME credits. Thank you so much. I'm going to leave that up for a moment, and I'm going to open up for questions. Thank you.
Thank you so much, Sharon. One quick question is we couldn't really see the bottom of your slides, and particularly we have a question about the link for help at the bedside. Is that available on any of the links that you have up here now?
Oh, yes. If you go to the AGS Co-Care Help site, if you go there, and I can also put it in the chat, I think.
Okay.
Oh, I stopped sharing. Where are my slides?
I can put the those links in the chat.
Okay, you'll put the link in the chat. Perfect. You'll put both links in the chat. Oh, thank you. Thank you. Okay. Everyone, the links will be in the chat.
Okay, great. And then moving on to the questions, no particular order. I'm going to first put in, getting a lot of questions. So one question I'll raise first is everyone's saying what a great talk you gave, Sharon, though. Thank you so much. And one first question I'll present is, could delirium be preemptive sign for people who will develop dementia or for early dementia rather than lead to earlier cognitive decline?
Yeah. So I'm so glad you raised that point, because I did mean to say that. So delirium is a sign of a vulnerable brain, no question. Okay. And so, yes, indeed, it can unmask a delirium. So that is true. And we see all the time. I know in my own clinic, I used to always be prepared, like right after the big holidays, that I was going to get a bunch of referrals, right? All of a sudden to my clinic for dementia, acute onset dementia. And it was because the family was not aware, and then maybe something happened over the holidays that precipitated an acute decline when family members were, when they were visiting or had their elder staying with them. So I saw that all the time. And then I did get also a lot of consults for acute onset dementia, right? When someone was hospitalized. And it just is because it's picked up at that time. And so it was just unrecognized, even though it was going on, once you get the better history. So delirium can serve to unmask an underlying dementia because it brings someone to the healthcare system, right? And then as you work them up and evaluate them, you say, oh yes, there's been problems longstanding. So the delirium brought, and the delirium goes away, but the dementia remains. So that does happen as well.
Thank you. And then let's see, a lot of good questions. All right. Great talk. ICU delirium has been associated with longer-term neurocognitive outcomes. Can you comment on correlation versus causation? This is a related question to what you just answered, maybe.
Yes.
Yeah, okay.
And that's a really good question and worth stressing again, that really we have accumulating epidemiologic, biomarker, pathophysiologic, and animal evidence that seems like delirium can lead to long-term cognitive decline, right? But none of that really is causal. It's associative at this point.
And then a couple questions on if people have an agitated dementia or delirium, I'm sorry, what are the, if you have to use a medication, are there any safer ones to use? So one idea, including valproic acid, or are there other, types of medications that may be safer than others?
Yeah, so that's a really good question. So, always you have to adapt to the particular circumstances of the patient. But if it's someone, where you have to treat because there's violence or there's risk of extubation or there's risk of injury, et cetera, then I would probably opt for something like Seroquel, one of the atypical antipsychotics, and again, depending on other meds, the side effects, if they're Parkinsonian, et cetera, you will adjust accordingly. But I probably would start with one of the atypicals at a low dose and try to get the behavior under control that way. Try to steer away from the benzos if that's possible, because benzos really can prolong the delirium and are not well tolerated. Valproic acid, I know it is being used quite a bit now. It is also associated with delirium, and unfortunately it has a long half-life. So I tend to steer away from it. There are circumstances, right, where you have to resort to using some of these medications. But again, I think for first line, an atypical, but again, with the caveat that the antipsychotics can also prolong delirium and may have worse outcomes associated. And so you want to try to taper them and get them off as soon as you can.
Great, thank you. Let's see, so a couple of questions related to other sites for implementation of the HELP intervention, particularly in nursing homes and the VA. Have they also utilized the HELP or something like the HELP intervention?
Yes, really good question. So we do have a site at the VA implementing help. I don't know how far along they are, but if the person asking the question wanted to connect with them, I could try to facilitate that. I think they're relatively early on, so maybe not even fully implemented yet. But there is a VA site. I know that's registered at AGS Co-Care Help. In terms of the nursing home setting, yes, indeed. Actually, Dr. Ken Bookvar has done a trial with help in the long-term care setting. Actually has 2 publications on that in JAGS. If you're interested, the spelling of his last name is Bookver, and I can put it in the chat. He calls it Help LTC.
Great, thank you. And then let's see. Is there? Go down here. And then dehydration came out several times in your talk as a risk factor. What degree of dehydration is necessary for this to become a risk factor, and what is its mechanism?
Yeah, so, you know, again, because in most of these patients, it's not just the dehydration, right? It's usually dehydration on top of someone who's very sick and not eating and not taking POs. And so it's that combination again. But typically we're talking, you know, substantial dehydration where you would see a bump in their BUN creatinine ratio. And so, you know, probably greater than a 10% degree of dehydration. What is the mechanism? I think that when people get dehydrated, at least in the older population, right? A lot of things don't function that well. Kidney function goes downhill. You know, any drugs that are metabolized through the renal route are probably not getting cleared. I think that might be one of the biggest contributors. They tend to start getting hypernatremic, which can lead to delirium. So a lot of things start to happen, right? And body does not function well being dehydrated. Dehydration is often unrecognized, my little pitch for geriatrics in older adults. They don't tend to drink enough fluids or free water, just commonly with aging. And so you want to be very aware of that. And that's why older adults during heat waves, you know, succumb. It's really the dehydration that becomes the issue. Okay.
Thank you. Guess if we have more time, I'll keep going. So how did the data translate to other populations like pediatrics, people?
Very good question. So, and I have to start by saying I'm not an expert in pediatric delirium. So if there's anyone else who wants to speak up, but pediatric delirium is being increasingly recognized, right, as also a serious problem in pediatric populations. There are a number of instruments to measure pediatric delirium that are validated, some of them based on the CAM, and they are all posted on our NIDAS website if you're interested. More and more, it's recognized that perhaps just as in older adults, in very sick children, delirium may have serious cognitive consequences. And I know that that's being looked at more and more right now. So more, I can just give you a teaser, but that is an area of very active investigation and interest.
Great. And then a couple more questions. Studies by Wes, Eli, and others have indicated inappropriate responses to sedation reveal a group of patients that will have long-term consequences of delirium in terms of cognitive decline. Can one use the responses to sedatives as a provocative test to find patients most likely to benefit from new therapies?
Yeah, that's such an interesting question. And in fact, a group of anesthesiologists contacted me recently because they want to launch a study looking at inappropriate reactions as someone is inducing anesthesia. You can see, you can follow the EEG on a BIS monitor, and there are patients who react quite unexpectedly during that initial sedation, and they've hypothesized perhaps these are people that are going to have very poor outcomes, in terms of developing delirium, developing long-term cognitive decline from the anesthesia. So I think it could be a similar phenomenon, could be a related phenomenon. I would say it's very important to look at. I would also say we don't know enough about it at this point, but no question, I think finding people who are at risk for not tolerating medications. And I know for a fact, and I know from my own personal experience, as well as experiences related to my father, that some people just do not tolerate any form of psychoactive medications and become more at risk of delirium and more at risk of long-term effects.
Do you have any tips for advocating for programs like help from health system administration? Yeah.
Oh, like how to convince
Yeah.
healthcare administrators that these programs are important?
Yeah, yeah.
Yes. Oh my goodness. This is right how I spend a lot of my time trying to convince healthcare systems and policymakers that this is really important. So yes, you have to start with evidence, right? I think the evidence is sort of the number one thing. I think we have that. We have very good evidence and just need to put that together. The other things that I have found myself are very effective. And just like every person is different, every health system is different, every health system leader and CEO is different, right? Like what they're going to be convinced about, what is on their radar as some of the most important things, concerns they have at that moment. So some of it is figuring out, okay, what is my organization most concerned about right now? And then how do I align the program with those concerns? How do I show them this program will help with their concerns? Okay, so what the heck does Sharon mean? So for instance, let's say your hospital has, or health system has listed their priority areas right now are patient satisfaction, age-friendly hospital, and retention of nurses. Okay, and battling COVID. Okay, of course that's on the top of everyone's list. Okay, well, you can show, right, how help aligns with all of those things, right? So if it's about patient satisfaction, there are so many published studies showing improved patient satisfaction with help, and family satisfaction, and nursing satisfaction with their jobs. I think there are even publications on nursing retention with help. Okay, then if it's battling COVID, right, you present all the evidence of how important delirium is during COVID and how help can assist with battling COVID. If it's the bottom line, right, if it's the dollars, we have all the published studies about cost savings. The AGS Co-Care Help even has worksheets. They have business tools that you can utilize to show how much your hospital will save once a help program is set up. And sometimes that's meaningful to administrators. So you just have to align, right? In age-friendly hospital, help is the original age-friendly program, right? For 35 years, addressing those 4 M's, right? That's what we've been doing. So there's no question. So you just have to find out what those priorities are and then align all your messages to show how you will help your organization meet their priorities. And that's how to do it.
Thank you, thank you. So I didn't even get to answer all the questions, but please, those who didn't get their questions answered, contact Sharon at the Aging Brain Center email. I'm sure she'll be glad and her team to answer your questions. Thank you so much. Wonderful.
Thank you. Thank
Thank
you.
Dr. Inouye. It was a terrific talk. We appreciate you.
Oh, I'm so glad. Do you think it went over well?